very warm welcome to all the delegates that are present online, as well as the faculty that is present with me. I'm Dr. Yogesh Sharma, working as a senior medical advisor at Abbott. And today I am pleased to welcome you out to the Grand Rounds in Rheumatology, which is a joint collaboration between Abbott and IRA eConnect. This is a session number 2. We had our first session in the month of August with Dr. Nigel Haroon in the disease area, which was axial SPA. And today we are going to speak about a more prevalent disease, which is very common in India, seen by the rheumatologists, which is rheumatoid arthritis. And today we are going to talk about the latest advancements and innovations in the field of rheumatoid arthritis by the experts, which are international as well as Indian. Before moving out to introducing the speakers for today's program, let me extend my gratitude towards Team IRA eConnect because of their seamless collaboration and support. This program was fruitful and being executed. So I would like to thank the Team IRA eConnect. And moving on to introducing to the faculty that we have today, we have an international speaker who is an expert in the field of rheumatoid arthritis. We have Dr. Gerd Burmester from Berlin. He has been a principal investigator for multiple trials, be it biologics or oral JAKi. He has also been the past president of EOLR in the period of 2017 to 2019 and been awarded with the highly cited researcher and top medical doctor by Focus Maxim. He has, to his credit, more than 950 publications which are published in an index journal. His research interest, again, to reiterate, it's rheumatoid arthritis, immunotherapy, biomarkers, as well as tissue engineering, which is seen. Yeah. So we welcome you, sir, on board. Moving on to the Indian expert, we have Dr. Ramesh Jois, who works as a consultant rheumatologist at Manipal Hospital. He has keen interest in rheumatoid arthritis as well as vasculitis, and to his credit, there are more than 50 publications. He's also the convener of Karnataka Vasculitis Club and vice president of Indian Rheumatology Association of Karnataka chapter. Presently, he is the scientific co-chair for this year IRACON, and he has been showing his research topics in various national as well as international conferences. We welcome you on board, sir. Moving on to the moderator, we have Dr. Damodaram, who is a consultant rheumatologist, Subodhaya Rheumatology Hospital at Tirupati. To his credit, he has more than 25 publications, out of which 7 are in international journals. He has shown keen interest in research, and he is also the past EC member of Indian Rheumatology Association. He has also been the founder and secretary of Rheumatology Association, Tirupati chapter. We welcome you, Dr. Damodaram, for moderating this entire scientific program. Moving on to the last piece that I will be presenting you today is the program agenda. So just for the kind perusal of all the delegates and faculty, we would start with a quick introduction addressal by our president of IRA, Dr. Chandrasekhar, followed by the introduction and context setting by Dr. Damodaram. Then we quickly switch gears and move to rheumatoid arthritis session, which is particularly emphasizing on the EOLR 2024 update, which is quite relevant and pertinent to our Indian practitioners. This would be a 30-minute talk, followed by we have a panel discussion, a very attractive and interactive discussion that we'll have between Indian expert Dr. Ramesh as well as the international speaker Dr. Gerd, and moderated by Dr. Damodaram on 3 clinically relevant points, which is JAKi efficacy and safety, adalimumab plays in therapy, and how to manage difficult to treat RA. This would be followed by a quick Q&A of 15 to 20 minutes. I urge every delegates to quickly to pay attention and put their questions in real time as in when you get it or during after the session. We would try to address most of these questions which would be moderated by Dr. Damodaram. But if there is anything that if you miss, we will try to get it through emails, the answers for your questions. And the session would be concluded and summarized by a quick vote of thanks by Dr. Vinod Ravindran. I now hand it over to Dr. Chandrasekhara for a quick addressal to the delegates. Sir, you're on mute.
Sorry, I think I'll restart. Good evening, everybody. Welcome all of you, including who are on the board with me today for the lecture, as well as the delegates who have logged in for listening to the lecture which is going to coming forth. This is third among the series of the eConnect lectures, and of course the second one among the grand rounds. And today we are going to get into the depth about the latest advances and the possible targets with reference to rheumatoid arthritis. And I think you have been introduced to the speakers and the moderators. With this, I welcome Dr. Damodaram to take over and set the context, and we'll go ahead with this. Welcome you all onto the board.
Good evening, everyone. Today we have an international speaker, Professor Gerd, to speak about the latest updates in the treatment of rheumatoid arthritis. And you all know the early detection is very key, but there are several potential targets, especially after the anti-TNF induction, the TNF therapy introduction. There are more number of potential targeted therapies in established rheumatoid arthritis. And also there is much more focus in the prevention of complications in rheumatoid arthritis patients, especially infections, long-term malignancies, and major adverse vascular events, and also the osteoporosis. So in this context, we like to invite our eminent speaker, none other than Professor Gerd, to deliver his lecture about the latest innovations and the how to prevent the major adverse events in patients with rheumatoid arthritis. Over to you, Gerd, sir.
So thank you very much, Dr. Dhawan, and thank you very much, dear colleagues from India. So very welcome to all of you from Berlin, where we currently have 15 degrees centigrade, so it's more on the fresh side. Autumn is coming to Germany, and so it's really a pleasure for me to give this lecture about the latest news on rheumatoid arthritis. I will share my screen. I hope it's going to work beautifully. Okay. Can you see the screen? And I will go to presentation mode. Everything fine? Okay, so thank you very much again. And you see here, this is the place I'm working. This is the Charité University Hospital. Our ward is at the 17th floor. This is the German Rheumatism Research Center, which is close by. And this is how the Charité was looking several hundred years ago. However, of course, today I will be reporting about latest news, particularly from the EULAR event we had in Vienna in June. And there is a lot to report, and I will just give you a few details. I cannot cover all of it, which was done in rheumatoid arthritis. These are my disclosures. And now let's go to the EULAR Congress. It was a very nice venue, as you know. If you haven't been to Vienna, I strongly encourage you to go there. It's a beautiful city, but also the fair area where the Congress took place was very nice. We covered a lot of items like debates, like recommendations, oral presentation, quizzes, and so on. So I think it was a very, very lively conference here in Vienna. So one major item that we always discuss in rheumatoid arthritis, but also in many other rheumatic diseases, including, of course, lupus, is vaccination. And I will just show you two examples, what I believe is very important news. So one was presented by Kevin Winthrop, who is an infectious disease specialist from Oregon in the United States, also a good friend of mine, and he's can also rightly be called an honorary rheumatologist because he is so heavily involved with questions in rheumatology, particularly regarding infections and vaccination. So one important question that always comes up when I give lectures on JAK inhibitors is, Well, and I will come to that later, herpes zoster has been defined as one major problem. How can we avoid this in our patients? Because I think you all know that shingles and especially the ophthalmic or the ones in the head and also at the trunk with post-herpetic pain can be really a terrible disease. So how to avoid it? And so the patients were in this study already on upadacitinib plus background methotrexate. So they really received two immunomodulatory drugs, the JAK inhibitor, upadacitinib, and background methotrexate. And we took advantage of the Select Compare study, where blood was sampled at baseline at week 4, at week 16 and week 60, and according to the regimen how the vaccine Shingrix is applied, dose 1 was given at baseline and dose 2 given at week 12, and then it was investigated if, despite this immunomodulatory therapy, there was a decent vaccination response. The clear answer is shown here. Interestingly, already at week 4, there is a considerable proportion of patients treated with these two drugs achieving humoral response to the recombinant zoster viral vaccine. So you see that more than 64% of patients got this response, and obviously after a second injection, more patients did, and that was quite stable even around week 60. The colleagues also looked into the humoral response by both baseline age group and by glucocorticoid or corticosteroid use at baseline. The good news is, and I think that is very important because we also have elderly patients, it worked. Nevertheless, if it didn't really matter if the patients were younger or older than 65 years, and if they used glucocorticoids, of course, not more than 10 milligrams, that was mandated by the trial, at baseline. So these are very good news. And there's even more good news to come. There was also a very good proportion of patients treated with UPA and background methotrexate achieving cell-mediated immune response to the recombinant vaccine. So very good news. Despite the immunomodulatory treatment, which was ongoing, most patients really received both a humoral and a cellular immune response. Obviously, we don't have yet the data because that would take years about the prevention of the shingles in these patients, but I think this is a very good surrogate parameter. So Kevin concluded most patients receiving long-term treatment with UPA plus methotrexate achieved humoral and cell-mediated response at week 4, 16, and 60. Achievement was not affected by age and concomitant corticosteroid use, and that is also important. I didn't show you the data because I can just verbally state it. It was well tolerated with no serious adverse events within 30 days post-vaccination. So this is also a question the patients ask, well, doctor, it may be effective, but what does it do to my underlying disease? Will it be more active? Will I have more flares? This was obviously not the case. Another very interesting approach regarding vaccination, and not easy to follow in daily clinical practice, I think we can discuss it later, was the time frame for initiating methotrexate and vaccination protection against pneumococcus in rheumatoid arthritis. This obviously is also a major problem in our patients, that they might get a pneumococcal pneumonia, which sometimes even is fatal. So to vaccinate against it is very important. However, we all know that against many bacteria and viruses, methotrexate really leads to a problem. Obviously, as I mentioned, not with the shingles vaccine so much, because this has a lot of adjuvants in it, but maybe towards influenza, COVID, and also pneumococci. So what these colleagues did is they used a vaccine and did a prime boosting, and then investigated what it would do if you wait for 1 month with the treatment of an early rheumatoid arthritis until after the vaccination, or if you treat patients immediately upon the vaccination. So one group is the delay group. You do the vaccination, you wait for 1 month, and then you start treatment, or you start with treatment immediately. And you see this on this graph on the right-hand side. There is quite a difference. If you delay, you have a much higher vaccination response against nearly all serotypes compared to the immediate treatment. So that's why the authors concluded, and they used in this case the PCV13 vaccine. Of course, we have now other vaccines as well. Administered 1 month prior starting methotrexate allows a significantly higher immunological response. Immune responses were still significantly in the delay group in 1 year, and no differences, and that is of course very important, were reported on disease activity and the use of glucocorticoids and targeted DMARDs at year 1. So because one might say, okay, you have the delay, you may get a better response to pneumococci, but maybe the disease is going on during that time and you will have a worse outcome. But this was not the case as shown at 1 year. So next question was addressed. This is also very important because we all have patients in our daily clinical practice who come in and say, oh, doctor, I got a flu. I don't really have a high fever, but I cough a little bit. And should I now delay my treatment with a biologic? And that was done and studied in a Dutch trial. They investigated continuation versus temporary interruption of immunomodulatory agents during infections. And the bottom line is temporary interruption or continuation of the immunomodulatory treatment resulted in similar outcome of infections. So these findings, the authors conclude, suggest that continuation of immunosuppressive treatment is safe, although precision was somewhat limited due to the low event rates in both groups, which I think is also a good thing. So they say, okay, we need probably larger studies, but this is already quite a good finding that we apparently do not need to discontinue our biologic treatment if the patient has not a very important infection. Okay, of course, a lot was addressed regarding the JAK inhibitors, particularly with regard to safety, and also new JAK inhibitors were introduced. I will focus a little bit on sort of regaining trust in JAK inhibitors after the oral surveillance study. So what do the EULAR recommendations say? Because they are in line with the EMA recommendations. They had been presented in 2022 and then published in 2023 by the lead author Josef Smolin and a large panel, and I had the privilege to be among that panel. So I will just mention a few highlights from these new recommendations, the major changes compared to 2019. You all know, and we can discuss it later, that there is a debate between the United States and Europe. The United States basically saying you shouldn't use glucocorticoids at all in rheumatoid arthritis. EULAR says, well, short-term glucocorticoids should be considered when initiating or changing conventional synthetic DMARDs in different dose regimens and routes of administration, but should be tapered and discontinued as rapidly as clinically feasible. So there we entered discontinued. Usually after half a year, there should be no glucocorticoids on board anymore, but it's very important and very nice, I'll come to that later, in the initial treatment. Next item that was changed after glucocorticoids have been discontinued and a patient is in sustained remission, dose reduction of DMARDs may be considered, and it didn't matter which DMARD, if you had a combination, you considered, you discontinued because the data are good for both of them. And finally, of course, a lot of attention was placed on recommendation 8, which was changed from the 2019 wording, which reads, if the treatment target is not achieved with the first conventional synthetic DMARD strategy, when poor prognostic factors are present, a biological DMARD or a targeted synthetic DMARD should be added. So it didn't really matter at that time what you did, biologic or JAK. That was amended to a biological DMARD should be added. But JAK inhibitor may also be considered, but pertinent risk factors must be taken into account, and these include age over 65 years, history of current or past smoking, other cardiovascular risk factors, or risk factors for malignancy. So another item that arises from the JAK inhibitors is what about infections? And that was addressed by a very large study led by colleagues in Switzerland, and was presented by Ramesh Jois. And so they investigated many patients in registries across the world. You see, ranging basically from Canada to Russia, from Norway to Turkey, huge data numbers, and they were looking for infectious event under JAK inhibition compared to TNF blockers and other mode of actions. So these are the data, and you see already that one is sticking out. This is the herpes zoster, but you don't see much different with the others. And when you look now into the adjusted incidence rates, the gray line in the center of the forest plot would be the TNF inhibitors as a reference. Then the green ones are other mode of actions, IL-6 inhibition, abatacept, or rituximab. And the orange line is JAK inhibitors, and basically there is no significant difference between JAK inhibitors and JAK inhibitors, while there is between the other mode of actions. The all infections, and particularly important, all serious infection, no difference compared to the TNF inhibitors. There is one difference that you see here. That is, I will use the pointer. This is here, of course, the herpes zoster, and we will come to that later on, which is really a much higher signal with the JAK inhibitors compared to TNF and the other mode of action. So this is something you need to take serious. So the bottom line is the colleagues did not find a significantly higher risk of infections or serious infections in rheumatoid arthritis patients treated with JAK inhibitors except for herpes zoster. So we also had the opportunity to look into large databases with upadacitinib across rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis. And we had the chance to really look into 15,000 patient years of clinical trial data. I will not go into the details of the table on the right-hand side. I will just read to you that with the exception of serious infections and PSA, herpes zoster, and elevated CPK and non-melanoma skin cancers, the rates of treatment emergent events were generally similar between upadacitinib and adalimumab and methotrexate in this analysis. You can also look into the benefit-risk analysis of upadacitinib versus adalimumab in patients with rheumatoid arthritis and higher or lower risk of cardiovascular disease. Here, the bottom line is that regardless of baseline cardiovascular risk status, UPA 50 milligrams generally showed comparable rates of adverse events relative to adalimumab, again, except for herpes zoster, and in both short and long-term analysis across cardiovascular risk categories, patients receiving upadacitinib demonstrated consistently better clinical and functional outcomes than those receiving adalimumab, and therefore the conclusion was the overall benefit-risk profile was favorable for upadacitinib, independent of risk group, and the benefits were more apparent in patients aged less than 65 years, of course with less comorbidities and so on, without CV risk factors. And you see here in this analysis that upadacitinib, if you also look at CDAI or the CRP, this would be here the dotted line, had a higher drug survival compared to adalimumab in this investigation. Okay, what about use therapies and strategies? Because we need to look forward with new possible strategies. And one was to use very early abatacept in patients. As you know, there have been 2 trials in pre-RA with good success of abatacept. So therefore, this question was addressed in this study, which compared subcutaneous adalimumab with adalimumab in a head-to-head comparison. And these patients had early dual seropositive rheumatoid arthritis, and most of them were positive for the shared epitope, and they had also an inadequate response to methotrexate. So this is we will say, a highly autoimmune group, being positive both for ACPA, for rheumatoid factors, and most patients also having shared epitope. This trial was called Amplify. Obviously, the hope was that, for instance, abatacept, based on these pre-RA trials, would fare better or even better than adalimumab. So this is the study design, abatacept versus adalimumab, and then a follow-up with abatacept plus androtenedione. So this is these are the primary outcome slide, and you see that even looking into ACR50 response, there was no difference as a sobering result between abatacept and adalimumab. Both basically had about 60% response rate with regard to ACR50 in this trial. And if you look into other parameters like 20 or 70, basically the curves are superimposable, as were the kinetics of response. So the let's say, a little bit sobering news was abatacept was not better than adalimumab in this setting, despite the super autoimmune populations. The good news is both drugs do very well. And you see here even a very high rate of patients with ACR70 in this group and a very high rate of ACR20. So both drugs did well. So it was comparable. There was some differences regarding biomarkers. We will address this later, but that didn't pertain to clinical parameters, and maybe a high anti-CCP subgroup may be a little bit better, but this needs to be investigated. Both therapies obviously were well tolerated and safe. One other trial that was done in Germany by Gerhard Krönke also had a very interesting approach, because here they performed a combinatorial treatment with rituximab and abatacept in patients with ACPA-positive rheumatoid arthritis, hoping that with a combination of these 2 drugs, you could really tackle rheumatoid arthritis better. Again, a sobering result. This combinatorial treatment with rituximab and abatacept did not really do better compared to rituximab monotherapy. So apparently this dual approach will not be followed anymore due to the not very encouraging results. One other investigation looked into the influence of rheumatoid factors on the response of patients treated with anti-TNF. And the interesting finding was that if you treat with a monoclonal antibody, that would be here the green curve, or a fusion product, etanercept, the survival of the drug was lower compared to certolizumab in patients with high rheumatoid factor levels, roughly 400 units here, and which is not surprising because the monoclonal antibody and the fusion products, they all have an FC part, and they may be bound by the rheumatoid factors and taken away by the mononuclear phagocyte system, while certolizumab doesn't have an FC part. It has polyethylene glycol, and in this particular patient population has a higher survival rate. So this is also very interesting to see the rationale here. Okay, so what about new therapies? Unfortunately, to my mind, we have to learn a new nomenclature. So you see that the WHO will, as of 2023, for the new agents being developed, change the names. So you are familiar with MAP, that is no longer used. It's now, if it's, let's say, an artificial monoclonal antibody, the ending is BART. And there is one new antibody, I will come to that, that is called Abipru-BART. Abi is sort of the first name that can be freely designated, but then Pru, you see this on the left-hand side, means immunomodulating or immunosuppressive, and BART means artificial monoclonal antibody. Outdated would be, as you see here, a MAP or ZOO or whatever. So this is, now we have to get familiar with this new nomenclature in the future, for the future product, and Abipru-BART already is one example. That was presented at EULAR, and it is an agent that interferes with the CD40 ligand interaction. It's a humanized monoclonal IgG4 antibody, binds to CD40 and thereby inhibits CD40 CD154, and was investigated in rheumatoid arthritis in patients who had an inadequate response or were intolerant of currently available biologics or targeted synthetic DMARDs. These are the results. It was a little bit complicated because several cohorts were investigated, but it met the primary endpoint, namely the change from baseline in DES28-CRP versus placebo at week 12. You see, the curves are not that much apart. That was already also commented in the session. Here it is more impressive, and we're going to see how this drug will do in the future. So the primary endpoints were met, comparable activity across weekly, bi-weekly, monthly dosing, and it was well tolerated, and therefore it will be developed in other autoimmune diseases and potentially rheumatoid arthritis as well. So now let's have a look into very new therapies, and one where you may have seen already the two articles, one from Berlin, another one from Erlangen in Germany, where they use the T-cell engaging monoclonal antibody. Blinatumomab is an agent that both binds to anti-CD3 and anti-CD19, and the results, I will come to that, were presented at EULAR and have been published in Nature Medicine. And teclistamab, which is a BCMA, a B-cell maturation antigen, which is targeting even plasma cells, which CD19 doesn't do so well, or only to a very small extent. And teclistamab also is an antibody which has CD3 in addition. So these agents, they glue together, not in this case the myeloma cell, because that's where they were developed for, but let's say the target B cell, and then the B cell or the plasma cell is killed. And so teclistamab I will not allude to because this was just published recently, a week ago, in the New England Journal of Medicine. I will show you the blinatumomab data, and you see here that this agent in very refractive, we will come to that maybe in the discussion later on, was quite effective by this antibody, which both addresses CD19 and CD3. It led to a rapid decrease in clinical activity, including synovitis on ultrasound and PET-CT, and also B cells were depleted. And this suggests the potential of BiTEs, bispecific T-cell engagers. You should remember that designation. And this is, of course, a very, very interesting approach, which we will probably see in the future as well. So, of course, EULAR also addresses recommendations, and the EULAR points to consider on the initiation of targeted therapies where in patients who had inflammatory arthritis and a history of cancer. There is a EULAR task force which has these not really recommendations because the data are not that sufficient, but points to consider. And so points to consider are treating inflammatory arthritis effectively in patients with a history of cancer is very important. Also to reduce the potential associated risk of malignancy, for instance, B-cell lymphoma and so on. The risk of complications should be balanced against the potential risk of targeted anti-rheumatic therapy-related cancer recurrence. And finally, the rheumatologist should engage with other specialists, of course, the oncologist. I will just allude to some points to consider. Appropriate targeted anti-rheumatic treatment can be initiated without delay. You don't have to wait for 1, 2, 3, 4, 5 years. No, you can use it right away in patients with a cancer remission. The JAK inhibitors and abatacept may be used with caution only in the absence of therapeutic alternatives if there is a history of cancer, and when targeted anti-rheumatic therapy is indicated in patients with a history of solid cancer, anti-cytokine biologics such as the TNFs or the IL-6 inhibitors may be preferred. When targeting anti-rheumatic treatment is indicated in patients with a history of lymphoma, obviously B-cell depleting therapy may be preferred, and in patients with a malignancy not in remission, nevertheless with an active inflammatory arthritis, remission of malignancy, of course, the decision to start targeted anti-rheumatic treatment should be based on a shared decision between the patient, the specialist caring for cancer, and the rheumatologist. And we all have, unfortunately, this situation that the patient has both a highly active rheumatoid arthritis, cancer. What do we do now? And that should be discussed among each other. So another very interesting points to consider was put forward by Frauke Förger, also at EULAR. And interesting point 5a, all TNF inhibitors may be used throughout pregnancy. This is interesting. And the following non-TNF inhibitors may also be used if needed to effectively control maternal disease. You see here, abatacept, anakinra, a large list. I say it's surprisingly large list, but what should not be used because we simply do not have enough data. This is anifrolumab, eculizumab, guselkumab, pembrolizumab, and risankizumab. They should only be used if there are no other drugs. So there is quite a liberal approach now to this kind of treatment. And finally, vaccination of in utero exposed infants. Non-live vaccines can be administered to all infants after exposure to any BMARD during pregnancy. Administration of live attenuated vaccines during the first 6 months after delivery is dependent upon timing of maternal exposure to biological DMARDs during pregnancy, transplantal passage of the biological DMARDs, and the type of vaccine. Obviously, JAK inhibitors should not be used during pregnancy at all. That is, of course, also a recommendation, not put forward here, but according to the product characteristics. So artificial intelligence was addressed. I don't have enough time to do that here. I will just show you one example by Thomas Hügler from Lausanne in Switzerland. And interestingly, his sister is working at a major car manufacturer that you know, who's producing electric cars. And they, of course, are also interested in autonomous driving, therefore pay a lot of attention to characteristics, lines on the streets, and so on. And he got together with his sister and said, okay, if you have a non-swollen joint here, you have these foldings or these folds. If you have a swollen, you have less folds. And how can you use this using artificial intelligence for a decision if there is a flare or not? So basically, the patients can take a picture with a smartphone, set it in, and then this can be done by artificial intelligence telling you, you see the heat map or here the finger fold index. Yes, there is a flare because of a swollen joint, or no, the folds are fine. And so I think this with an accuracy of 0.84, which is quite remarkable. So I will close now with one more things, but actually two more things. One I feel is quite interesting because there was a very interesting study in the Netherlands looking into the long-term effectiveness of a lifestyle intervention for rheumatoid arthritis, 2-year follow-up after the plans for joints randomized clinical trial. So this is a very interesting practical approach and program. People learn about and follow a whole food plant-based diet and receive advice on sleep and stress management exercise. The program lasts 16 weeks, and the diet was a plant-based diet version of the Dutch dietary guidelines with a focus on unprocessed food. It was rich in whole grains, legumes, nuts, seeds, fruits, and vegetables, but there was no calorie restriction, interestingly. And also the exercise was done following the Dutch exercise guidelines, which advise 150 minutes of moderate to intense exercise per week, as well as twice weekly muscle strength exercises. And the very interesting results are that significant improvements in disease activity were observed after this particular plans for joints intervention. Up to 2 years, one average medication could be slightly reduced, and that is clear indication and a very nice proof that indeed intensive lifestyle modification can also be effective to reduce disease activity in a non-medicine related version. So very, very interesting, and we can discuss it later. Finally, there was a very interesting on difficult to treat rheumatoid arthritis, the role of anxiety and depression. I cannot go into all of these details. It was put forward by a Norwegian group. The conclusion here is that there was quite a negative impact of anxiety and depression on RA patients in standard care, which really underscores the challenging in disease activity assessment in these patients. And ultrasound examination overcomes some of these items and may be a valuable objective tool in the evaluation of these patients who complain about a lot of disease activity and bad global and pain scores. But when you do ultrasound, you do not really see much. So that is really putting us into a better position to evaluate these particular patients. So my final slide is addressing Barcelona in Spain. So the next EULAR meeting will be in a year from now, in June, again in Barcelona, Spain, in a very beautiful venue that you see here. And of course, everyone is invited to visit EULAR to learn more about future and current approaches to treat rheumatoid arthritis, but of course, many, many other rheumatic conditions. So with these words, I thank you very much for your attention, and I end my presentation here. Thank you very much.
Yeah, that's a wonderful presentation by Professor Gerd, and I covered almost all aspects of the disease, right from the diet, exercises, psychological components, and also the newer potential therapies in the treatment of rheumatoid arthritis, and the safety of the various biologics and small molecules, and also the newer pathways for the treatment of rheumatoid arthritis, especially multi-drug resistant rheumatoid arthritis. So with this, we'll go on to the second phase of our program, that is the panel discussion. So for that, I welcome Professor Ramesh Jois and Professor Gerd. And we have a few set of questions. We categorize these questions in three sections. One is the JAK inhibitors section and adalimumab section, and the difficult to treat section. So, can you see my screen?
No, not yet.
Yeah, I think now can able to.
Yeah, now we can see it.
Yes. So the first question: refractory rheumatoid arthritis in elderly patients with or without any CVD risk factors. Would tofacitinib make a good treatment choice in standard dosages, or can we use a low dose tofacitinib in this subgroup?
Maybe I can start it because this is as you mentioned, a refractory RA patient who probably has undergone, let's say, methotrexate, IL-6 inhibition, TNF inhibition, and maybe even abatacept. So in this patient, even the EMA recommendations would say, okay, there are no other suitable alternatives available. So in this case, I would certainly consider a JAK inhibitor. The question is that is, of course, would be off-label to use only 5 milligrams per day, but that would be a consideration, starting with maybe 5 milligrams, and if the patient tolerates it well, go to twice 5 milligrams, because that would be covered also by the EMA recommendations. And we all know, and if you talk to colleagues working in geriatrics, they tell you, well, the JAK inhibitors, they are basically very good drugs because it's just one pill. You don't need methotrexate on board. It makes treatment quite easy in this elderly patient population that, in addition to our anti-rheumatic treatment, gets anti-diabetics, anti-osteoporotics, anti-hypertension, and so on, where sometimes the treatment is quite complex. So I would say, yes, you can do that.
So I'll just add a couple of lines to so just inform you the Indian context, Professor Gerd. We don't have abatacept in India. We don't have cetralizumab in India. Most of the therapies now, the intravenous therapies, because the insurances don't cover intravenous therapies for rheumatoid arthritis, most of the therapies are now subcutaneous, and subcutaneous biosimilars is the sort of most widely available biologic therapy in India. But because India has a self-paying system where the patient has to pay for his treatments, and most insurance companies do not reimburse biologic therapies, people are forced to either shell out of their pockets to buy the biologics, or if they cannot afford, the only best option or the cheapest option is the generic tafastinib, which is very widely available now and which is much, much cheaper compared to combination DMARDs of methotrexate, sulfasalazine, hydroxychloroquine. If you're going to use the three of them, it's easier to use tafastinib and more economical than a combination DMARD. So I think Dr. Damodaran's question comes in this context. And when we look at it, we have majority of our patients who have never tried the biologics because of the prohibitive cost, the anti-TNF biologics, I mean, the prohibitive cost, where we are left with the combination, with the option of either a triple combination or go to a JAK inhibitor. So, this is what happens to a majority of our patients. And in practice, as you rightly pointed out, I've been using JAK inhibitors. I use the cutoff thing of 70, 65 years only to remind me, but I don't keep that as a prohibitive age to use JAK inhibitors, because controlling the disease becomes more important than the perceived cardiovascular risk, because uncontrolled disease in itself is a huge risk factor for cardiovascular outcomes. So, that's my thought. Correct me if I'm...
I couldn't agree more, because we must not forget that the population that both EMA and FDA recommendations were based on is a very unique, very high risk population, primarily from the United States. I'm pretty sure if more European patients had been included, which was not possible for logistic reasons and other reasons at that time, we probably wouldn't even have seen that. Because, as you know, there was no significant difference in cardiovascular events. It just didn't reach non-inferiority. So I fully agree. But unfortunately, in Europe, we just have to live with this. And there is a black box warning. And so even though we don't believe in it, because I think this is not really appropriate, because it's based on a high-risk population, of course, that might be appropriate, but if you already have had a myocardial infarction, then your risk is high. So I fully agree that, and I would support your, let's say, very pragmatic approach. If I cannot get the other drug because simply I do not have the money, then I take what I can get. And if I reduce disease activity, I will also reduce cardiovascular events. I fully agree.
Thank you.
So this another question: the risk of herpes zoster with tafasitamab or any other biologics or DMARDs. Can we check antibody? Because in Indian context, we cannot give shingles vaccine routinely for every RA patients. So is there any cost-effective solution? Like, can we check the antibody titers before routine shingle vaccine to identify selective group, or any other cost-effective solution? Like, can we go for conventional varicella live attenuated vaccine in RA patients?
Yeah, maybe if I can start, this is a real problem because we know that the viral vaccine, which is an attenuated virus, the live vaccine, is not really very effective. There have been studies really showing that there is not a real efficacy there. And also, it's not easy to give a live vaccine during a JAK inhibitor treatment. So basically not very helpful. And while Shingrix is extremely effective, but I know that it is quite expensive in Germany. One injection, and you need two, is 110 euros, which is even on the cheap side because there are countries where it's even more expensive. So in total, the vaccination would be 220, 250 euros for Shingrix in Germany. So this is in Germany. It is of course covered if you are above 60 years old. If you have any immunosuppressive disease, then above 50. And we only had, let's say, the vaccination program against the young form of varicella since a few years. So our patients have not been vaccinated against varicella when they are 50 or 60 or so. So that's why we usually do not do the titer in our patients. We simply just vaccinate. But this is, of course, the European approach in affluent countries. And I'm looking forward to what you are doing in countries where you do not have that much, or patients may not have the money or the coverage to really afford Shingrix vaccination. Not an easy issue.
Yeah. So can we move on to the next question? In our Indian settings, like many of the treating doctors start tofasilinib directly in any patient with rheumatoid arthritis. Can we encourage such type of practice? And another one is, can we use tofasilinib with or without methotrexate in patients with early aggressive rheumatoid arthritis?
I just referred to the setting in India that we just discussed. I think that is important. And these patients obviously have not yet failed methotrexate because they are early, naive patients. So why not use both approaches here on top of each other? And because we know that this is usually we also recommend EULAR using methotrexate along with the JAK inhibitors. So especially if you haven't failed it yet, I would say yes.
I think
it's not covered by the European label, I must say. But let's say if you are on a pragmatic approach in India, and you may do that, I would support it, of course.
I think one of the problems in India is rheumatoid arthritis is not just treated by rheumatologists. The country is deficient in the number of rheumatologists who are available because most rheumatologists are concentrated in the cities, and the towns and the villages don't have many. So obviously, the rheumatoid arthritis is treated by a wide range of specialists, including orthopedics, physicians. So obviously, by the widespread availability of JAK inhibitors, or particularly tofasilinib in its generic form, most people have thought that it is a new molecule for rheumatoid arthritis on par with methotrexate, which is wrong. I think fortunately, most rheumatologists don't do this approach of not using methotrexate. It's the non-rheumatologists who treat rheumatoid arthritis who are too much excited about tofasilinib and take it as a first-line drug. So I think the onus falls on us rheumatologists to educate them to say that methotrexate is still the gold standard, even despite the other drugs, and only those who have failed or those who cannot tolerate methotrexate should be candidates for tofasilinib, unless there are very specific reasons, very aggressive disease who can't tolerate any drug, or for various reasons, other reasons, we might use it upfront. But still today, majority of our patients treated by rheumatologists do go on methotrexate.
Okay, I understand. Because in Germany or in Europe, that would be off-label and not normally possible. But let's say you could, of course, start with methotrexate, and if that doesn't work after, let's say, 1 or 2 months, because the disease is so aggressive, that you don't lose that much time when you add tofa at that stage. So that is a compromise then.
Yeah, so I will go to another question, like protocol for TB screening and the incidence in JAK inhibitors. Is there any newer guidelines to screen apart from the routine quantiferon TB Gold?
To be honest, we screen every patient with a new DMARD, with a targeted DMARD or a biologic DMARD for TB and do this routinely. The only exception is rituximab, where you don't need it. So this is already ingrained in our brains. But if a patient has been on an anti-TNF agent, then they have already been tested, then we would not retest in Germany. I know that India may be different because you have a higher prevalence of TB, which is low now in Germany. It used to be different many years ago. But nevertheless, we routinely do the TB screening, which is in Germany an interferon gamma release assay. So it's a lab test, and do a chest X-ray and do a thorough history. We do this regardless if it's a JAK inhibitor or a biologic.
So there's been some sort of debate amongst Indian rheumatologists about screening for tuberculosis prior to initiation of JAK inhibitors. That is because compared to the traditional anti-TNFs, the incidence is lesser from the clinical trials. Some of the Indian centers were also part of the JAK inhibitor trials, and obviously as a part of trial protocols, they did have TB screening, but even otherwise, a lot of people, were of the opinion that the incidence of tuberculosis is far less with JAK inhibitors compared to the anti-TNFs, even amongst high endemic countries. But being in practice now for a good few years with the use of JAK inhibitors, most of us have come across tuberculosis in patients who have been in JAK inhibitors. And most of us have employed the strategy of using quantiferon as his chest X-ray, as you rightly pointed out, and screen them and treat them for latent tuberculosis, because the incidence of latent tuberculosis is much, much higher in India compared to the West. So a lot of patients tend to get onto the latent tuberculosis protocols, TB drug protocols, along with JAK inhibitors. But personally, from my personal experience, I would say the incidence is much less compared to what we had seen with anti-TNFs. Nevertheless, we are still cautious. I still screen my patients, but traditionally we would wait with a latent period of first the tubercular drugs followed by the anti-TNF maybe 4 to 6 weeks later. Whereas with JAK, I may not do that. I might just start the JAK along with the anti-tuberculosis therapy. That's probably the only difference.
Yeah. I mean, you have much better data than we do because we see tuberculosis now quite rarely. And so it is not easy to judge because when everyone does the screening and treats preemptively, then of course we don't see over tuberculosis that much anymore. So it has, luckily in Germany, less and less of a problem. And mechanistically, probably the JAK inhibitors are better because TNF is probably a very important cytokine in controlling a latent TB.
Yeah, so now we move on to the biologic section in the context adalimumab, efficacy and safety in rheumatoid arthritis. The first question is for early aggressive rheumatoid arthritis. Can we start adalimumab upfront in combination with methotrexate?
Interestingly, that would be within the label. You could do this, unlike with the JAK inhibitors in Germany. But the recommendations, the guidelines, state you should always start with methotrexate first. And also the Optima trial shows that if you delay the initiation of adalimumab by, let's say, 3 months, the disease doesn't really get that much worse. So I would say, yes, in exceptional instances, you could do that, and it's within label. But normally, you would start with methotrexate, follow the patient closely, and maybe after 6 weeks, decide, should I, in this particularly aggressive patient, add adalimumab very, very early on. So the bottom line is we don't do an initial combination treatment treatment, even though it is within label. We wait a little bit for methotrexate to work. If it doesn't, then we rapidly add adalimumab.
We move on to the next question. How is the efficacy of adalimumab monotherapy? And is there any evidence to use monotherapy in any patient profile?
Yeah, we checked this to some extent in the Concerto trial, where we used 2.5 milligrams of methotrexate and not truly adalimumab monotherapy in addition to, and we could clearly show that 10 milligrams of methotrexate is really good in order to have higher drug concentrations of adalimumab and to avoid the development of anti-drug antibodies. So I would abstain from adalimumab monotherapy if really possible. Of course, we have patients who do not tolerate methotrexate or discontinue it or are in remission and no longer take it. And then, of course, you can also do it in monotherapy. But if possible, I always use methotrexate on board when I treat with adalimumab.
See, there's one more aspect to this, that biologic use in India is not for long term. It's used as long as the patient can afford. And while the patient has been in sustained remission, and when you want to withdraw therapy, the first drug to be withdrawn is obviously the biologic. So keeping methotrexate, background methotrexate, would help in preventing relapse of the disease or flare-up of the arthritis. So my take on this would be to always combine with methotrexate if the patient tolerates, so that you have a backup when you want to withdraw the biologic.
Yeah, and even more so, let's say you're treating with an expensive drug in terms of India, and you want to have the maximum result of that expensive drug, and that you will see with methotrexate on board.
Yeah. Another question is, would you switch between biologics or biosimilars to maintain the safety and efficacy in RA patients? And what is the switching protocol to follow?
Yeah, I think, no, that's an easy question. I would say yes. There are so many data with switching and adding and so. So basically, if you have a biosimilar that is approved by an agency like FDA or EMA, they're very safe and you can easily switch between them. I don't see any problem here. It's more, let's say, logistical problem because it's a different name. The syringe may look different and so on. But basically, the drug is very similar. So I say yes. And there is no protocol. We just change.
So now we're going to difficult to treat RA section. What is the optimal treatment approach to refractory rheumatoid arthritis or multi-drug resistant rheumatoid arthritis, or patients who has got an established rheumatoid arthritis which is poorly controlled? Can we maintain the disease with low disease activity as our goal?
Yes, and that's why I included my final slide on the depression and anxiety. I think that is a very important aspect. So first of all, I would look, why is that really a refractory RA? So let's say the patient has been on methotrexate, TNF blocking agent, IL-6, rituximab, JAK inhibitors, and still very active. Luckily, in my setting, these are very rare patients, luckily, that they're totally resistant and are very active and may have joint erosions upon X-ray. Then this is a real problem, and then I might think about experimental treatment as I outlined with the blinatumomab or something, because we have protocols in Germany where we could actually treat these exceptional patients. On the other hand, you meet in your, and I'm sure you have the same things in India as well. You see Mrs. Jones, and she says, well, I started methotrexate, and I just got some nausea. I ended methotrexate after 2 or 3 weeks. Then I got a TNF blocking agent, and I got some coughing. I ended TNF, and then I got an anti-IL-6 inhibitor, and after 3 weeks, I had some bowel problems. I discontinued. I got rituximab. I got some skin reaction after one injection, and I got JAK inhibitors, and I had, let's say, a little bit of acne. So these are patients that are not truly resistant, but they always find, I would even say, maybe it's not correct, some excuse not to continue that drug. So that is also something where I'm always very hesitant to call this patient truly resistant, because none of the drugs were really used in an extended version for a long period of time. And then I'll really try to convince the patient, okay, now let's do one treatment that's an anti-TNF drug, and I'll follow you closely, and let's have a look when there are any side effects, if they are truly related to the drug. And sometimes this works quite nicely, sometimes it doesn't. It depends on the psychology of the patient.
So I'd like to add something here. One of the important things that Dr. Malaviya's study from Delhi showed amongst patients with poorly controlled rheumatoid arthritis in India was suboptimal dosing of methotrexate. So majority of our patients are not brought on to optimal doses of methotrexate. So it's very important to make sure that before giving up on methotrexate, the dosing is optimal, the route that is optimal, because subcutaneous methotrexate is widely available in India, and make sure we use that before we recommend a biologic drug to most of our patients. Then, if a patient fails, then there are different practices that are done in India. There are many who vouch for rituximab because the compliance issues are better with rituximab. It's an infusion. You make sure you give it to all your seropositive patients. There are people who have done innovative approaches of using less than recommended doses of rituximab in India for economical reasons, and have shown that this approach is still sustainable in in a situation where the economy drives your therapeutic decisions. Obviously, we have generic adalimumab because the Humira never came to India, and etanercept, we still have the originator as well as the generic versions. And then we have tofastinib. But today, when you look at the refractory RA, truly, when I mean refractory RA, it is truly refractory RA. Majority of our patients have failed methotrexate. The option is whether you would want to combine leflunomide or whether you would want to go to tofastinib. The majority of the patients, when we look across practitioners, people have started using tofastinib as the next drug, mainly because obviously the combo is much better than leflunomide and methotrexate, or sulfasalazine and methotrexate in getting people into low disease activity or remission. So, we see a shift in the trend. For many years, where biologics were non-reachable, we would still see triple combos in India and leflunomide. Whereas now the thing is slowly shifting, and majority of the times we see methotrexate with tofastinib as the most preferred combination as your first line, when there are no relevant contraindications.
Yeah, very good, very good. Yeah.
And another question. There is an evidence of on increased incidence of ILD in RA patients who are on DMARD therapy. So, is that question is still valid?
Yeah, that's a very important question. And the good news is we always thought that methotrexate would be bad for the lungs. But at EULAR, a very nice presentation was shown by British colleagues, basically showing that no, it's just the opposite. Methotrexate is good for the lungs and also prevents the occurrence of ILD, as does, for instance, abatacept, anti-IL-6, and also good news for the JAK inhibitors. There has been one Turkish study in ILD with tofacitinib with also good results. So I think you should really control the disease with appropriate drugs, and including methotrexate, which does not cause ILD.
In terms of therapy, Dr. Gerd, you would agree that even probably tocilizumab as well as rituximab might also have a role for both the diseases, isn't it? Because given that tocilizumab works better in scleroderma ILDs, and at least rituximab has some role in the treatment of interstitial lung diseases. Since we don't
Absolutely.
have data on RA-ILDs, particularly we don't have trials to address, and most of the data is extrapolated from other interstitial lung diseases, particularly scleroderma. I think we do have many therapeutic options, maybe a bit of caution with anti-TNF drugs, but all the others should still be okay.
Yeah, absolutely. I fully agree. And so methotrexate is good. And so because these drugs usually do not cause the ILD, but they are not as good for treatment. And I fully agree that if you, let's say, are financially stressed, that even rituximab would be a good choice in this patient. Of course, rituximab for us is always the COVID problem with vaccination and so on. And so we used a lot of rituximab in our patients. Now we're a little bit hesitant because of COVID. Okay, I see the next question coming up.
Yeah, what are the new biomarkers to stratify patients and to predict therapeutic response or lack of response?
And I must say, sadly, there are no biomarkers available currently for routine practice. We saw very interesting approaches by our British colleagues and to do synovial biopsies and do gene expression studies and single cell analysis and so on. And there's some indication if you do so that you can stratify patients, but this is still on the research agenda. Currently, apart from, let's say, rheumatoid factors, ECPA, CRP, we do not have good biomarkers.
So, Dr. Gerd, I had a question for you. IL-6 is available in some of the Indian laboratories on a commercial thing, and this was sort of more widely checked during the COVID times. Can IL-6 be used as a biomarker in rheumatoid arthritis?
Not really, to my knowledge, because it's so tightly related to CRP that you don't get additional information if you do IL-6 analysis, especially rheumatoid arthritis. The debate is still on in giant cell arteritis and so on, because IL-6 is faster and CRP takes a little bit more time, but rheumatoid arthritis CRP is just fine.
Sure.
Yeah, now I will close this panel discussion. Now we'll go to the QA section from the audience. And most of the questions that was asked is already covered by Richard and in the panel discussion. And however, there are some few important questions. Do we need to vaccinate patients being treated with Shingrix who are less than 50 years of age? Is there any guidance?
Good question. Yeah. Let's say in rheumatoid arthritis, I would say, well, probably not. In lupus, I would say yes. Because lupus, even the young ladies get Shingrix. In lupus, I would vaccinate. In rheumatoid arthritis, it would be good. It doesn't hurt. And it is approved after the age of 18 in Europe. So once you are 18, you can be vaccinated with Shingrix, but it's not reimbursed until you are 60 normally, or 50 if you have an immunosuppressive disease. But in lupus, we ask the health insurance company for permission and for coverage, because lupus is the incidence of Shingrix, of shingles in Germany is pretty high with lupus. Not rheumatoid arthritis at this age group.
Yeah. So then another question, can we consider the intake of red meat and the disease activity? To what extent do you feel is this true?
I personally don't eat red meat anymore. So I have really. I'm not a vegetarian, so occasionally I eat a Bratwurst, as you know, a sausage in Germany. But I personally am more like a pescatarian diet, and I think red meat, even though the data are really not that convincing, is something that most of our patients avoid. I mean, if you eat a steak once per month, probably it's fine. But if you eat a lot of red meat, then of course I would discourage it, because you see the study from the Netherlands was quite convincing with a plant-based diet. So if a patient says I'm a vegan or I'm a vegetarian, I'm always happy, because then, of course, for a vegan, you need to supply vitamin D and E and so on. Not so easy. But if a patient is a vegetarian, I'm always very happy.
So, I mean, the problem with diet is different in different parts of the world.
Yeah, of course.
At some stage, Mediterranean diet was touted as one of the best diets, as an anti-inflammatory diet at some stage. I mean, a significant proportion of Indians are vegetarians. But despite that, we still see a lot of high disease activity. So I'm not sure, since we don't have a particular there's not much of research on even vegetarian diets, or say, for example, Indian-based diet. When my patients practically ask me what is the recommendation, I say no evidence. So I'm still allowing them to eat whatever they want.
Yeah. So particularly the vegetarian diet in India is so superb. You have so excellent food without meat in India. But of course, you may not have that much olive oil, the nuts, and so on, which may be very important for the vegetarian diet, and the special vegetables like eggplants and zucchini and so on. Yeah, but it's an interesting research question.
Yeah, and then can you screen for TB when you are starting tofacitinib? Is it must from your perspective, sir?
It is. I would say it's in Germany. It's routine. It's very easy. You draw the blood, you take the X-ray. It's even easier if the patient comes from anti-TNF, because then they have already been screened in the past. So then we don't do the screening if the patient has already been screened due to anti-TNF treatment. Otherwise, if it's a new patient coming from methotrexate, we do the screening for TB.
I think since most recommendations or guidelines recommend screening, I think it's better we stick to screening even for legal reasons. Say, your patient who you would have started on tofacitinib. As such, tofacitinib is an itchy drug now, especially with the cardiovascular warning. And, you have a patient who develops tuberculosis and you haven't adequately screened. I mean, people can easily fault you. So I think it is still recommended. It doesn't take much. If a person can afford a biologic, I think even in India, screening for an interferon gamma assay and a chest X-ray should not be so expensive.
Yeah. So imagine a case where you give a JAK inhibitor right away without screening. The patient develops an open active lung TB, is coughing, and the whole family is sick. And now the lawyer comes to you and say, well, you didn't do the screening, so the whole family is sick, and they're suffering from active TB. Not a good situation. I would follow the rules that you just outlined.
Yeah, and another question: in patients on triple therapy, and when tofa is considered, would you stop 2 DMARDs and add tofa to methotrexate?
Yes. I would stop hydroxychloroquine, sulfasalazine, keep the methotrexate on board, and add tofa.
And in patients with secondary amyloidosis due to rheumatoid arthritis, which currently stands burned out, if the serum amyloid associated protein or CRP titers remain high, would you treat with biologics to reduce inflammation and amyloid progression? In other words,
this is a more theoretical question, because I have not seen amyloid disease in RA for decades now. I used to see that when I started rheumatology a while ago, but now I don't see this anymore. If we see that, let's say sometime, I remember a young lady who came from the pediatrics setting. She had amyloid disease, and we could treat her very well with an anti-IL-6 agent, with tocilizumab. That would be my preferred agent.
I mean, given that we still see a lot of uncontrolled disease in India with high disease activity, I mean, even in these last 17 years that I've been practicing in India, I've probably seen hardly 2 amyloids in the context of rheumatoid arthritis, though I might see other things like rheumatoid vasculitis. We still see 1 or 2 a year. But amyloidosis, I mean, even I have not seen so many.
Yeah.
Wow. So another question, like if a patient who is on methotrexate and tofacitinib, who is in well controlled and in remission, and let's say patient developed the CL lung. So if that patient is being told that it is tofacitinib that has caused it, how can we explain our position?
What was the abbreviation again? I didn't understand it acoustically.
Yeah, a patient who is on methotrexate and tofacitinib, in case if he develops carcinoma of lung, and then if patient
difficult situation because that is one side effect that we see in the oral surveillance, because most of these were lung carcinomas and linked to smoking. So that is one drawback, because if you didn't inform the patient sufficiently, you may be in a problem if the patient develops lung cancer under tofacitinib if you haven't followed the black box warning in Germany. So this is what we really are afraid of in Germany. So therefore, we do a shared decision. We let the patient sign, and if the patient develops lung cancer, then of course we follow the EULAR recommendations and discuss it with the patient and the oncologist what to do best. Not an easy situation, you're right.
Yeah, so we came almost to the closure of the session, and the take-home message is like methotrexate is the main streamlined drug, and in refractory cases to methotrexate, then we need to consider adding biologics or tofacitinib, and then we need to give more importance to the infection prevention and also the vaccination in the patients who are taking biologics, and also the TB screening is must for anti-TNF. And in Indian settings where the TB is very high, even in the high-risk patients, we need to consider TB screening in those patients who are receiving tofacitinib. So with this, I will hand over to Dr. Vinod Ravindran for conclusion of the session.
Good evening, and at the outset, I would like to thank our eminent faculty, Professor Burmester and Dr. Jois, who have really taken us through the entire spectrum of problems we encounter in the management of rheumatoid arthritis, and also the therapeutic advances and some of the things we need to be careful about, particularly in the Indian context. And I thank Dr. Damodaram for his expert handling of the session with great skill as a moderator. Thank you to our president, Dr. Chandrasekhara, for leading us into this academic series of events, and also to Abbott for partnering with IRA eConnect for the curation and the delivery of this academic series of programs. With that, on the behalf of Indian Rheumatology Association and the IRA eConnect, with my team, Dr. Damodaram, Dr. Mohit Goyal, and Dr. Arghaya, I would like to thank everyone for joining us, and I wish you a pleasant evening ahead and a great weekend. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Bye-bye.
Thank you.
Thank you, Professor.
Thank you.
Bye-bye.